So let's talk about the different etiologies of hyperprolactinemia. What can cause the prolactin to be skyrocketing high? Of course, the big one on the boards is there a pituitary adenoma, a prolactinoma? Another name for that is always a lactotroph adenoma. Why? Is because prolactin is produced by the lactotroph cells of the anterior pituitary, and so that's why you could use the names interchangeably, lactotroph adenoma or prolactinoma. Could it be a hypothalamic disorder, like taking place right above that pituitary? It would be very, very rare for a hypothalamic disorder to cause hyperprolactinemia in clinical medicine and on the board exams. But what's a very reasonable choice and something to evaluate is medication induced. And what drugs do we think about? Number one category, dopamine agonists. And what are going to be some examples of that? I put phenothiazines, which are the classic typical antipsychotics. When I think about those, there was a lot of anti-dopamine effect on these medications. That's why we start using the atypicals more. But of course, even the atypical antipsychotics do have anti-dopamine effect. So classic typicals are things like haloperidol, atypicals, and I'm going to just kind of intermingle with a lot of brand names, things like Abilify, things like Geodon, things like Risperidone, things like quintonapine, brand name Seroquel. I mean, they're atypicals, they work on other neurotransmitters too, and have less anti-dopamine effect. The typicals, lots of anti-dopamine. Of course, one of the things we worry about when you take a typical antipsychotic long-term is what we call tardive dyskinesia. So another pearl for your board exams, but of course, remember, prolactin is under inhibitory control by dopamine. So if you use any type of these anti-dopamine medications, you're going to get that. Metoclopramide goes by the brand name Reglan, and I would think about using metoclopramide for diabetic gastroparesis. Sometimes we use it just for when you're nauseated. And of course, what does it do? It speeds up the GI tract, metoclopramide. And how does that work? Is because when we talk about the GI tract, it's going to have both sympathetic and parasympathetic interventions. And it innervates at places called Meissner's and Auerbach's plexuses, names that you probably haven't heard since USMLE step one. Take home message is that parasympathetic speeds up the GI tract, sympathetic slows it down. So the neurotransmitter, when we talk about sympathetic intervention, is dopamine. So of course, if you use a medication like a metoclopramide, it inhibits dopamine. Prolactin goes up, and you get no sympathetic intervention from the GI tract, unopposed parasympathetic. So what happens? Everything kind of speeds up, which is why it helps for things like gastroparesis. And of course, opioids slows down the GI tract. Another etiology is hypothyroidism. I mentioned already TRH, direct stimulant of prolactin release. Next would be chronic renal failure. We don't like to use the word chronic renal failure. It just sounds really mean, right? You're failing. I like to use the word CKD, chronic kidney disease, and of course, CKD comes in different stages, 1 to 5, 5 meaning you're on dialysis. And the reason why prolactin goes up is that what is the main job of the kidney is to clear substances from our blood, right? It's the whole filtering process. So of course, if you have worsening CKD, your glomerular filtration rate, GFR, is going to go down, and you're going to start accumulating prolactin in the blood. And last is going to be pregnancy and lactation, which is why when someone comes in, they're a woman of the reproductive age, you want to get a pregnancy test. And of course, lactation, the process in itself, will increase prolactin. Pregnancy, it's the estrogen, right? The more estrogen that you have around, the more prolactin is going to be released.